start over now. So the first thing with the heart exam is inspection, all right? Very similar to the lung fields. Again, really it's cardiopulmonary. So what we're assessing for is any signs of inadequate circulation. So what were the two things in the hands, specifically the fingers, that we were assessing? Clubbing of the fingernails, and what was the other thing I had mentioned? Splintering hemorrhages, okay? Another thing also too, remember cyanosis, or just any evidence of paleness. You can even feel if there's any temperature changes in the upper extremity or the lower extremity. So again, any signs of potential poor circulation. One very important thing that you must assess with the heart exam is pedal edema. Does anybody know what pedal is? Pedal, P-E-D-A-L. What is that Latin for?
No, it's Latin for walking. Foot.
Ankle. Foot, right? So edema is a sign of heart failure. The heart isn't adequately pumping. Remember, what happens after the capillaries give off oxygen? It has to go in through a venule. It has to go through the venous return. Does anybody remember where does all the blood eventually end up? Coronary sinus, superior vena cava, inferior vena cava, right? That whole junction there, right? So what atrium does it enter in? Hey, now we're talking, right? So if there's any malfunction with the right side, either due to, and again, we'll kind of go into more pathology, in fifth semester, you're going to start to have a backflow of blood. And one of the things that's going to happen is it's going to start pooling. Because most of the gravity, obviously, there's going to be a significant amount of gravity here at the ankles, it's generally going to pool there first. So, easy way to check it, you can actually leave them on. If someone's wearing crew socks like this, honestly, they do the job for you. What you'll see in older patients, when you pull down the sock, is you'll actually see, and he's got, really, you can just see the ridges, but you don't see an indentation. Patients with pedal edema will actually have an indentation in the skin because the sock, the elastic compression, is actually kind of compressing the fluid. Another way to check it if they're not wearing socks is you literally just push in. And as soon as you release, you should see the skin immediately bounce backwards. In something called pitting edema, when you push in nice and hard, you'll actually see your thumbprint, okay? Now again, not for this class, but it's measured. That sometimes you'll see in charts, grade 1, grade 2, grade 3, and usually this is the amount of time it requires the actual edema to unpit. All right, so edema is something that's very, very important because it's usually early signs of congestive heart failure. Congestive heart failure, especially in your elderly population, is usually the #1 admission to an emergency room. I cannot tell you the astronomical cost that it does. Anybody that heard me on last Wednesday, I discussed in great detail about the cost of care. So just kind of by doing, again, preventative medicine, well, this is one of those things where preventative medicine is so important, all right, because we really want to, be able to intervene in conjunction with blood pressure, all right? Blood pressure, pedal edema generally go hand in hand. So really make sure that you're doing a good, thorough inspection. And quite frankly, I would say on any patient that has a history of high blood pressure, check the ankles, period. Even if they have absolutely no chest wall complaint, no chest pain, but anybody that has a history of high blood pressure or they're on some type of high blood pressure medication, it doesn't take much to check the ankles because you'd be surprised. A lot of patients, they start blood pressure medication and then all of a sudden, when was the last time you saw your doctor? I don't know, 6 months, 12 months, 18 months, and they're on the same dosage and the blood pressure has been uncontrolled, let's say, for a year. So CHF is definitely one of those things that you really got to be on the lookout for. All right, so just to recap real quick with our inspection, all right, we're assessing the fingernails, we're assessing for any discoloration in the hands, any temperature changes in the hands, also in the ankles, any evidence of cyanosis, anything that would lead us to indicate poor circulation, and we're assessing for any edema, okay? Now, here's a quiz, just a random oral quiz here. We did it with the head and neck. What other finding could indicate poor venous return or right-sided heart failure? All right, what is that? What are you doing?
Distended
Yep.
jugular vein.
Yeah, very good. Jugular venous distension. All right, so edema in the ankles coupled with jugular venous distension, you'll actually see the jugular vein popping out. that's a very bad sign, all right? These are patients that, where would you refer somebody with those signs to?
The emergency.
Not necessarily. What's that? A vascular specialist?
Cardiologist.
Cardiologist. Yeah, more simple, a cardiologist. Okay, so that's that. All right, so that is the inspection. Now, what I'm going to do is I'm going to go down the list first. All right, and then what I'm going to do is I'm going to show you a trick, because what you're going to see in the notes is we're going to have the patient supine, and then I got to sit him back up to do part of the exam and then lay him back down. So let me do it first so you guys see all the technical components, and then what I'll do is real quick, I'll show you kind of a shortcut that you can do in practice to prevent the patient from having to go seated to supine, back to seated, and then back to supine. All right, so the inspection is done just like we did. It doesn't matter what side you're on. Now what we're going to do is, Doc, can you throw me that pillow there? We're going to have the patient lay supine, okay? So slave. I'm actually going to have you switch, buddy, because I want everyone to be able to see me. All right, so from this point on, the exam is done from the left side of the patient. So anytime that the patient is supine or seated, we're always going to be on his right side. All right, so just keep that in mind. The reason why is it just makes things a little bit easier for your hand placement, and you're able to hit all the points that you need to hit. All right, so, sorry, can you take that off? Apologies. Obviously, this exam is going to require, proper gowning techniques, okay? One of the things that we're first looking for, all right, is after inspection, I want to do something called, I want to assess for the PMI. All right, the PMI stands for the point maximal impulse. All right, I'm going to show you how to both assess it supine and also while you are seated. And basically, the PMI is really only present in about 20% of the population. Not everyone's going to have it. The PMI is going to be located. Now, if you guys kind of don't remember your intercostal spaces and mid-clavicular lines, now's the time to dust the cobwebs off. All right, because those are your landmarks. All right. What the PMI is basically it's a point that we can assess to see if the heart is enlarged. All right, so it's at the apex. Where is the apex? Is it at the top or the bottom when it comes to the heart?
Bottom.
It's the bottom, right? Because it's a little bit different. Usually you think of an apex, think the apex of a mountain. But remember how the heart is shaped. So the point of maximal impulse is going to be at the most bottom point at the apex of the heart. And that's going to be located at the mid-clavicular line, at the fifth intercostal space. So you can see real quickly how you're really going to want to make sure that you understand your thoracic landmarks and you have a good idea of where the clavicle is, because that's going to become very important. So again, the PMI should be located at the mid-clavicular line and then at the fifth intercostal space. And what you'll actually do is you can kind of get down on the level and you're looking to see if you actually see a pulsation. Now, if you don't see it, you can use something called tangential lighting, where you can actually take a pen light or whatnot, and you can kind of angle it so that way you can see it refracting off the skin. Sometimes it makes it a little bit easier for you to see an impulse. If you don't see the PMI, don't worry about it. It's okay. Like I said, it's only present in about 20% of the population, all right? So, that's the only place where you should see a pulsation. Okay, again, fifth intercostal space at the mid-clavicular line. If you see pulsations anywhere outside of that, that's an abnormal find. That warrants an immediate referral to a cardiologist, okay? Means that there's something wrong. All right, I'm going to show you again a quick little shortcut how you can palpate the PMI with auscultation. So first what I want to do is I want to palpate for something called thrills. A thrill is an abnormal pulsation. Thrill is not the PMI, because remember, the PMI is normal. That should be there, okay? So a thrill is basically a visible pulsation that you can see or that you can palpate. Now, can you guys get a good look and you see everywhere? Because this is very important. There are palpatory points and oscillatory points. So I'm going to go through the palpatory points first. So if you can't see, now's a good time to kind of come around and see where we're going to go with this. All right, so basically you can use two fingers, use your finger pads, and really all you're feeling for is a pulsation. The first oscillatory point is the aortic point. The aortic point is located at the second intercostal space, parasternally to the right. So right here. And you can see I'm depressing a little bit, and I'm just seeing if I feel a pulsation. Luckily for him, I do not. Okay? So this is the aortic palpatory point. All right? The pulmonic palpatory point is at the second intercostal space, parasternal to the left. Same thing. Okay? Now, in your female patients, you basically can have them use their hands to either move their breast tissue up, move it down, out of the way. All right, but you do need to assess these points because they are important. All right, so again, you have your aortic point, you have your pulmonic point. All right, next one is called Erb's point. Erb's point is located at the third intercostal space, parasternal to the left. Okay? Now, the ectopic is a palpatory point only. All right, you're going to learn that the oscillatory points, we have an aortic, we have a pulmonic, we have an Erb's. We don't have an ectopic oscillatory point. A lot of people get dinged on OSCEs for that, all right? So ectopic is only palpation. Again, highlight that, make a mental note. If we see you doing an oscillatory exam at the ectopic point, that's not appropriate, that's wrong, all right? So the ectopic palpatory point is at the third and fourth intercostal space at the mid-clavicular line. So again, here's his mid-clavicular line, here's his third and fourth intercostal space, there's the ectopic palpatory point. And again, just feeling for an abnormal pulsation. Okay? Next, we go to tricuspid palpatory point. That is located at the fourth, is it fourth and fifth? I think, no, it's just fourth, right?
For tricuspid?
Yeah.
Tricuspid 1 is 4, tricuspid 2
But for
is
palpatory,
5th.
I believe it's just the fifth,
Yeah,
correct?
Usually you're just doing 5th.
Right. So the tricuspid palpatory point is at the fifth intercostal space, parasternal to the left. Okay? So again, here's the sternum. I go just to the left, and I'm at the fifth intercostal space. All right, good. Now, the mitral, all right, this is also the PMI. All right, so the mitral or PMI is located at the fifth intercostal space at the mid-clavicular line. And again, if you're close to the nipple line, just have the patient, can you take your left hand and just move your pec tissue up a little bit for me? Yep, and just move it up. Good, so that way that's covered, okay? And any awkwardness you can easily mitigate. So I go to his fifth intercostal space, I go to the mid-clavicular line, and now this I do want to feel. And I do feel something. The question is, how big is it? The PMI should normally be the size of a penny. If it's the size of a nickel, yeah, it could be a little bit enlarged. He's in very good shape, so it may be normal. If it's anything bigger than the diameter of a quarter, then that usually indicates that the heart could be enlarged. That's an abnormal find. Now, the apex of the heart should also be pointing to the left. Does anybody know the name of the condition if the heart is actually pointing to the right? What's that? So sinusitis inversus, and that just actually goes for any visceral organs where it actually mirrors it. So if the apex of the heart, so let's say you're here, you don't really feel anything. You know what? Not a bad idea. Real quick, go to the other side. Because if all of a sudden I feel a PMI here, that's not good. I will say it's less than 1% from epidemiological research. So it's very, very rare that this does happen, but it could, all right? And usually it's just a congenital anomaly. But again, you still need to get that person evaluated by cardio. The contour, again, it should be nice and strong. It shouldn't feel weak. And again, it should be the size roughly of a penny. Now, if you feel the PMI lateral to the mid-clavicular line, normal or abnormal? What's that? Abnormal. Again, it means that the heart could be enlarged. All right, we don't want the heart to be enlarged. A dilated heart is not good. This is critically important for those that are really involved in youth sports. Remember, you hear those stories of younger kids, going into cardiac arrest and having myocardial infarctions because they've had an enlarged heart that was never diagnosed, okay? So if you get involved in doing sports physicals or anything like that, and if you're tasked or if you have the privilege to be able to do a sports physical, you really got to make sure you're doing a very, very, very thorough job because you don't want to miss an enlarged heart, okay? All right, so reiterate real quick our palpatory points. We have aortic, we have pulmonic, we have herbs, we have ectopic, we have tricuspid, and we have the mitral, aka the PMI. And again, the PMI is the only one we should feel. If you feel a pulsation anywhere other than the PMI, what is that called? What's that known as?
Thrill.
A what? Someone I heard said, thought I heard say it.
Thrill.
A thrill. Very good. Normal or abnormal? Abnormal. Emily, what would we do if we felt a thrill?
Refer?
To who?
Cardiologist.
See how easy that is? Exactly. Very good. All right. So that is our inspection. All right. Now, if you feel a PMI and it's in the correct spot, you don't really need to percuss. Now, here's a note about percussion. I'm going to show you it. All right. We're going to practice it, but I'm not going to test you on it. Why aren't I going to test you on it? Because quite frankly, the evidence behind it is pretty weak, and the National Board Exams has omitted it. So when you take part 4 of your board exams, you will not be tasked to percuss the heart. I'll show you for completeness because it's always good to practice our palpation, our percussion skills. All right. So again, patient is supine. I'm standing on the right side of the heart. Okay. What we're going to do is I want to start lateral to the midclavicular line, and I'm going to work my way medial to the sternum. What I'm assessing for is when do I hear the heart dull. So it should be resonant, 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 and then it's going to dull out. All right. It should become dull really parasternal. If it dulls out at or lateral to the midclavicular line, again, it means that the heart's probably dilated. Now you're going to learn real quick why they kind of threw this skill out, because it depends on the person's body habitus. If somebody has, large muscular pecs or, large breast tissue, it's going to be very, very, very challenging. But again, it's good to practice percussive skills. So real quick, I'm going to go from the 2nd, 3rd, 4th, and 5th intercostal space. I'm going to do each one individually. So I will start lateral to the midclavicular line at the 2nd. And again, very difficult to hear when it dulls out. But you can hear it change right there in him. All right? So that's normal. All right? It should become dull medial to the midclavicular line. So I would do that for the 2nd, 3rd, 4th, and 5th. Again, if you hear any dullness lateral to the midclavicular line, again, it could indicate dilation. Okay? So we got that. Any questions so far on palpatory points and the percussive points? So far, so good? All right. The last and probably the most important is oscillatory, okay? So for this, all right, I'm going to obviously not put these in my ears. So I want you to take note. Remember, you have a diaphragm and you have a bell. And in your scopes, it's a matter of a twist. So before you start the oscillatory exam, very gently, don't do this because that hurts. Just very lightly scratch the surface so you can see if it's activated or not. If you don't hear anything, flip it over. All right, I see a lot of people, they get flubbed up on OSCEs when they can't hear anything. They get nervous, it throws off everything. Relax, your stethoscope works. Probably just have it clipped off to the wrong side. All right, so when the patient is supine, I'm going to be using the diaphragm. Again, when the patient is supine, I'm going to be using the diaphragm only. Again, when the patient is supine, I'm going to be using the diaphragm only. All right? Now, keep in mind I have similar oscillatory points than we just went over. So the aortic, where was the aortic palpatory point located? 2nd intercostal space, parasternal to the right. Where's the oscillatory point? 2nd intercostal space, parasternal to the right. Yeah. Now, Everyone does it a little differently. I like to take my 2 fingers and kind of have the bell like this. All right. I want to avoid having my fingers on the chest because I don't want any abnormal sounds. All right. So I'm holding it here and I'm listening. Okay. I'm going to listen for a few seconds. I want to hear a lub-dub, 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 lub-dub. All right?
You should do 1 full respiratory cycle.
Exactly. Okay? At least. So don't do this. Lub. I mean, I've been on physicals. Anybody ever had a physical exam where the doctor just did this? Nice and quick. I had one literally like 6 months ago, and I laughed. Like, seriously, guy? That's comforting to know. So, if you're not sure if you heard the full cycle, it's okay. At least 1 full respiratory cycle, but listen as long as you need to get the information, all right? What we're trying to listen for, and we'll go into a little bit more on Thursday, is murmurs and abnormal heart rate, all right? So you should hear a lub-dub, lub-dub, lub-dub. The timing is pretty even, right? Well, there are patients with a lot of different conditions. And in 5th semester, I'm going to show you how to use EKG, that you can actually see the electrical conductivity. But when you're oscillating, an abnormal heart rhythm could be lub-dub, lub-dub-dub, lub-dub, lub-dub-dub, So, that would obviously be a cause for concern. So that's really what we're listening for. Is the timing between S1, S2, and then S2, S1, similar, all right? It is important to know, so let me just break this one out. This is the only kind of lecture material I'll give you in regards to murmurs. All right? S1 is the first noise you're going to hear. All right? Lub. If you are actually holding a pulse, and this is one of the things I used to do on the ambulance because it was very difficult sometimes to hear fully. Systole is what? Do you feel the radial pulse during systole or diastole? Systole, right? Yeah. Systole is when the actual ventricles are pushing the blood and I'm feeling a pulse. So the S1 noise is you're going to hear it during systole. So if I were to have if I'm feeling his pulse, when I feel the pulse, I should be hearing S1, give or take. S1, noises are made when valves close, okay? So when you hear a valve close, that's what you're hearing. That's the S1, S2. What they mean is they're different positions. So what valves in the heart do you guys think would close first? You have the atrioventricular valves, and you have the semilunar valves. Semilunar valves are your aortic and pulmonic, and then your atrioventricular you have 2 of them. What are they? Mitral and tricuspid. So the first noise, what valves would close first? Think about it. The atrioventriculars, right? Because what's happening? As the ventricles start to squeeze blood, there's going to start to become a little bit of backflow, and in a perfect world, the 2 atrioventricular valves are going to slam shut to prevent any regurgitation. So that's what we're hearing, okay? So as the ventricles are pumping out blood, I'm starting to feel his pulse. That first lub is the atrioventricular valves. And again, you have 2 of them. You have the mitral, which is where? Between what? Left atrium and left ventricle. And tricuspid? Right atrium and right ventricle. Very good. All right? So you guys can see, right? I'm trying to dust off some of the cobwebs because this is stuff that you're just going to have in the back of your mind. Because when we start getting into murmurs, you're going to learn how can you detect, a stenotic valve or a mitral valve prolapse. You'll be able to do that after next week. All right? So brush off on your cardiac fizz. All right. So let me go back now. So again, I have my aortic oscillatory point, and I'm listening for lub-dub. Which noise would be louder here, S1 or S2? So where am I? Aortic and pulmonic valves are S2, right? So this one, so S2 is going to be a little bit louder. So maybe a lub-dub, 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 all right, because I'm right over these semilunar valves, okay? The pulmonic oscillatory point is the same as the palpatory point, all right? Parasternal to the left at the second intercostal space. Herbs stays the same. parasternal to the left at the third intercostal space. Here's the change. Remember, ectopic is only a palpatory point. It is not an oscillatory point. Instead, like Doc and I were talking before, you have tricuspid 1, which is located parasternal to the left at the fourth intercostal space, and then tricuspid 2, which is located at the fifth intercostal space, parasternal to the left. Okay? Then we go to the mitral. Where was the mitral located?
Between the left and right.
Midclavicular line at the fifth intercostal space. Excellent. Very good. Now, one of the things too I want to assess for is sometimes I want to be able to hear for a mitral murmur. And sometimes it's easier if I lay him in the left lateral decubitus position so I can get a sense of, maybe I do hear a little bit more of a murmur, because what it does is it forces the heart to kind of translate a little bit laterally to the left. So I'll have him, can you get on your left side for me? It's okay. And you can see how you got to kind of reach over a little bit. So watch your body position, and I want to listen to see if I hear a murmur. Okay? All right. Yeah, I can hear. You're fine.
Can you really?
I'm just kidding.
No.
All right, so sit on up for me. All right, so that is the exam supine, okay? So again, I started off with my inspection. I laid him supine. I did my palpatory exam for thrills. I did the percussion, and then I did all of my oscillatory points with the diaphragm. Now, I want to have him seated. Where do I stand? Right, left? To the right, right? So why don't you come on over here. So you swing your legs here. And basically what I'm going to do is here, it's just oscillatory. Okay? Now, here's the change. Oscillatory points are identical. Here's what changes. Okay? For the aortic, for the pulmonic, and for herbs, correct me if I'm wrong, we're using diaphragm, correct? Okay. So again, aortic, pulmonic, and herbs will be done with the diaphragm. So he leans slightly forward, same position. All right, I'm listening, aortic. I'm coming over to pulmonic. I'm going down to herbs. For the remaining three, so for our atrioventricular valves, I want to flip over to the bell. So for tricuspid 1, tricuspid 2, and mitral, I will be using the bell. Okay? So again, nope, you're leaning forward a little bit. Tricuspid 1, tricuspid 2, and mitral. And similar to how I had him in the left lateral decubitus position, all right, I can have him turn towards me. Yeah. Doesn't matter, right? Yeah, again, these are one of those things that, the evidence is So you can, if you don't do it, it's not a big deal. That's just kind of the way that was in Bates, last edition. So, all right, and that's it. Okay. Now, let me show you some real quick tidbits because, like I said, I had to get him from sitting back to supine, back to seated. Now, if he's got a chest wall problem or whatnot, I want to try to minimize, some things. So, what you can do is after you perform the inspection, okay, do everything that we did. You can go to auscultation. That's okay. Again, just make sure if you're going to do auscultation, you're using the diaphragm for what valves? What oscillatory points would I be using the diaphragm for? Aortic, pulmonic, and herbs. Good. So from inspection, I'll go right to auscultation. Diaphragm for aortic, diaphragm for pulmonic, diaphragm for herbs. I'll flip over for the bell for tricuspid 1, tricuspid 2, tricuspid 3. You can also palpate for the PMI if you would like. So sometimes what I'll do is, from here, your hands, you can literally just slide your index finger off the bell a little bit and just tell the patient, I'm just going to palpate your chest wall real quick. All right? And then you can palpate the PMI in that position. Okay? After I do that, then I would have them go supine and I'd complete the rest of my exam. So I would do my palpation for thrills, making sure I hit every point, okay? I would do the percussion, again, practice it, but you know, we're not going to really test you on it. And then obviously the auscultation. Okay? Does anybody have any questions? All right, let's practice that, all right?